I'm Dr. Michael DiTolla.
And I'm Megan Strong.
Your partial denture success could hinge on today's case of the week.
And find out which states got an A and which states got an F on their dental report card.
And in Texas, a woman loses her teeth and then fakes her own kidnapping. What a cliche. That and more on today's Chairside Live. Hey now, hello and welcome to episode 99 of Chairside Live. Megan, we've done 99 episodes, but a bridge ain't one. Actually, I take that back. We have featured the Bruxer full arch prosthesis, which is technically a bridge. So
yeah, we
99.
Have
how you doing?
99 episodes. I'm doing really well. 30 weeks pregnant today. So that means 10 weeks or less, which is terrifying and exciting at the same time. But yeah, so I can't believe next episode is our 100th episode.
I was lecturing out at the Texas Dental Association this past week, and a lot of people came up and said to tell you hi. But two different dentists came up and asked, is Megan really pregnant? As though this were some thing that we were doing for ratings, you know, like some stunt pregnancy, and then we were going to reveal at the end that you weren't pregnant or who the father was, or I don't know. So I don't know. I thought it was funny when two people said, is Megan really pregnant?
That is so funny to me. Yes, to those dentists out in Texas, I am very much pregnant.
Right, well, bring the little stick in.
Oh, gosh, come on. But it's obvious. I don't think that it's really...
I know. I don't know what they thought we were doing. Prosthetic bellies or something like that. Anyway, we've got an interesting show for you today. We got a good case of the week. I was in the partial denture department the other day walking through, and I wanted to see some of the common issues that they run into. And I happened to look down, and on the topic of stress breakers, there was a couple partials sitting there that utilized the DE hinge, or the distal extension hinge, something that when I talked to dentists about it, about half of them haven't heard of it. So I thought it'd be interesting to share that with you. Let's go ahead and take a look at that now. I was in the partial department the other day, and I noticed a case a doctor had sent in that I thought was kind of interesting. It's a Kennedy Class 1 situation where we are edentulous bilaterally here and behind our remaining teeth. And it presents some challenges because we've got some tori that you can see down here, at least 3 of them, kind of odd, with 1 here and then 2 over on that side. And then we're going to have some issues with clasp retention too, especially on this tooth. Eesh, you can see that. And you know, it's one of those cases where we've got some good rest preps, which is nice. We've got a nice little stop over here in the lingual cuspid, and then a nice occlusal rest on the distal of the bite. But we want to avoid the tori, of course, so the patient's not going to be back in the office in pain, complaining. We want to clasp in a way where we're not going to destroy the abutment teeth, rock them out, or the tissue around there. And the dentist had requested a DE hinge, a distal extension hinge. And with that hinge, we're able to clasp a circumferential clasp around the cuspid. So if you haven't seen a distal extension hinge yet, this is what the framework actually looks like. And that is the hinge. You can see it on both sides. And the hinge simply, as you can see, provides a stress breaker between the saddles and the major connector. And so typically in a situation like this, in a Kennedy Class 1 with bilateral edentulous areas, when the patient chews down without a stress breaker, we've got rotation on the abutment teeth, and that tends to force them in a distal direction. And so on a tooth and tissue-borne partial like this, if it's a rigid unit, the teeth are going to take the majority of the brunt of the stress. But when we have something like this, where there's a DE hinge, now all of a sudden we're transferring a lot of the stress that's generated during function while the patient's chewing down here. Because of the stress breaker of the hinge, it's being transmitted to the edentulous ridge and sparing the anterior teeth, especially the ones that are clasped. It's sparing them that stress and pushing them distally and doing damage by making them more mobile. And so the edentulous ridge takes up more of that stress. Of course, we're going to see faster resorption of the ridge because now when the patient chews down, because of the hinge, the saddle is going to be able to be pushed down even harder. And so we're going to see quicker resorption of this, and as a result, we're going to see that it starts to fit maybe a little bit loose as it resorbs underneath that saddle. The saddle will continue to go down with the ridge, but then it'll also come back up again with sticky foods. And so one of the disadvantages is that kind of feeling of maybe looseness, if you will, as the ridge resorbs underneath it. But of course, it can be, relined as well to that new tissue height. Over on this side, we really can't get below the infrabulge, and so that's another good reason to put this hinge, because otherwise, when the patient bites down on here, it's just going to have a tendency to want to pop that clasp off of the tooth, or at least raise it up on the tooth, and we will lose retention for that reason. So again, as the patient loads this with the DE hinge, that stress breaker is going to take stress off of those abutment teeth and put it onto the ridge. So it kind of depends, what kind of condition the abutment teeth are in and how strong they are and what the ridge looks like underneath it. And certainly if you write in and send the case into the lab, our technicians can help you decide whether or not you want to go with something like this. But you can see how with the patient chewing on this, all of a sudden, we're not going to have the same kind of torquing of those abutment teeth that we would when this is designed as a rigid unit. So certainly something to consider in a case like this where we have bilateral edentulous spaces. And of course, we're able to stay above the tori as well, stay clear away from the tori so that we don't cause any pain. And there was another case sitting right next to it. And again, the same kind of thing. We've got tori on both sides. We do have some rest preps that were provided by the doctor, which is really nice. So again, kind of like on the last one, we're going to do another lingual plate to avoid the tori. But here we have just a unilateral edentulous space on this one. So, the concern is that as the patient loads the denture on this side, on 18 and 19, the right side is going to rock and dislodge because, we're putting all the force on the partial here, this unilateral force. It's only coming from one side. And so this is another time where a distal extension hinge is going to keep the partial from unseating when the patient bites down onto this. It'll reduce the issue. And so as the patient loads the denture teeth, the saddle will give into the ridge and not torque the abutment or the partial denture. So again, this is a good use of a DE hinge when you have a patient like this, so that we're not popping this off, rotating around this axis down the middle with the patient biting just on this one side. Again, it allows that stress breaking, so we've given the saddle the ability to move up and down without torquing the rest of the partial denture. Now, one thing to keep in mind is that we do have to consider the occlusal clearance here. We need room to put a denture tooth over the hinge still. So the lab typically is going to need 5 millimeters from the gingiva where the hinge is going to be, 5 millimeters from here up to the opposing. And as long as that 5 millimeter exists, there is room for the DE hinge and the denture tooth. You'll notice both of these are mandibular cases, and the technicians here really don't like to do DE hinges like this on maxillary partial dentures. The hinge has a tendency to loosen, and the saddle has a tendency to drop, whether it's from gravity, just kind of over time, away from the ridge. And so it's one of the reasons why this is a real popular choice on mandibular partial dentures, but you're not going to see a lot on maxillary dentures because it just doesn't have the same efficacy and the same comfort for the patient. But when you've got, whether it's a bilateral edentulous space or a unilateral edentulous space like this, and you're concerned about the longevity of the abutment teeth, certainly it's a good thing to bring up to the technician the possibility of placing a distal extension hinge, a DE hinge, to act as a stress breaker and take some of the pressure off these abutment teeth and put it on to the edentulous ridge.
Thank you for that, Dr. D.
You're welcome.
Now let's go to a segment we call Viewer Mail. Well, before we get started on today's viewer mail, I want to talk about a viewer mail that we received a couple weeks ago from Dr. Dewey Nguyen in San Francisco, California. And if you remember that episode, I pleaded for Dr. Nguyen to send me some sourdough bread. I love San Francisco sourdough bread. It's the best thing in the world. And lo and behold, can you believe it? He delivered.
He did.
He sent us sourdough bread from two famous bakeries in San Francisco. And you actually were out of town.
I was in Texas.
You were,
right,
when people were questioning my pregnancy. And so I took the bread home. to scarf it down. No, actually, Brandon and I, my husband, we made a couple different sandwiches, and the bread was absolutely incredible. So thank you so much. That was incredibly kind.
That's pretty awesome that you just throw that out there, and he took the time to go to the bakeries and send
Right?
it and wrap it and make sure it was still fresh. And did you happen to grab any pictures of the sandwiches?
I did. We can look at those now. I made the first sandwich that I made was it was a chicken salad sandwich, which I had actually grilled the chicken, and so it had a little bit of a smoky flavor. It was delicious. And then the second sandwich was actually a chicken sausage panini that I did with fresh basil and marinara and chicken sausage and mozzarella cheese. Unbelievable.
Well, it sets a great precedent. Instead of us giving things out to the viewer mail people,
I know,
they get read on the air and then they send us local delicacies.
Yeah. Here. Well, we're going to break bread together.
All right.
Right now.
We're going to eat it together?
Yeah.
Who's going to talk?
Anybody.
Okay, well, you start eating and I'll talk. Thank you, Dewey. That was very nice of you.
So good.
Yeah, when I was up there, I went to dental school in San Francisco, and Bodine was the only sourdough, bread in town. But kind of like with donuts, like Sidecar Donuts down here, there's this whole artisan movement towards making quality products and not necessarily mass producing things. And it looks like it's happening for sourdough as well.
Yeah, it's so good. I love it.
Well, I'm going to enjoy this while you read this week's
All right,
viewer
well,
mail.
chew quickly because you got to answer it.
Okay.
This week's viewer mail comes to us from Dr. Stephen Devins, and he writes and says, in the past, with any type of crown, especially cast crowns, we used a dye spacer on the dye. It was usually 1 or 2 coats of something like nail polish. Now, with Brexer, Emax, Lava, CAD-CAM, etc., I don't see it being used. What happened to the room to allow for the thickness of the cement? Thank you, Dr. Stephen Devins.
Well, Steve, I kept wondering when a dentist was going to ask us about this, and you're actually the first one that I know of to write in and ask about it, and it's a really good question because you're right, for decades you would see dyes, and the dye spacer we used was blue, and it was kind of like a nail polish, and we would put it on, 2 coats of it, and you would get a crown back and you'd see the red line marking the margin, then you'd see the dye spacer stopping short of the margin but covering the rest of the prep. And then all of a sudden one day it was gone. First, like you said, with the CAD-CAM restorations, and now it's gone with everything because every crown that we make here today and every day is CAD-CAM now, even the PFM. So you will never see dye spacer on another die again from us because it's all done in the design process now. So when you send in a polyvinyl siloxane impression, we pour up a stone model and we articulate the stone model, we saw out the die and all that good stuff, and then we take it to a 3-shape scanner, we put it in a box scanner, and we scan the prep arch, the opposing arch, and then we close them together with the articulator and do a buccal scan so we get the relationship for that. And then we design a crown that's going to go on that preparation virtually like a CEREC doctor would. And when we do that, there's a default virtual dye spacer of 90 microns that goes across the entire prep surface and stays short of the margin. Now, one of the big advantages of this is that it's always 90 microns. In fact, I'm going to put an image up here on the Chairside Live Telestrator. A little heavy. And as you look at this, you can see on the left the conventional dye spacer. So this is just a random dye that we pulled out of production off the floor that has a coping on it, and we sectioned it, and you can see that on one side by the margin there's 50 microns. On the other side it's only 20 microns thick, and then up top we have 300 microns of dye spacer, and so most of the contact for that crown is going to be at the margin, and it's really that irregularity on the different parts of the prep where we could never really dial in uniform dye spacer. So if the top of the preparation was like it should be, kind of concave to mimic the occlusal surface of the tooth, you can imagine the dye spacer pooling, and that's where you see in that image that it's 300 microns thick. The other thing we noticed is that some technicians would leave the top off of their dye spacer, and the acetone would start to evaporate. Their 2 coats of dye spacer would be way thicker than if you got a new bottle and shook it up and actually kept the lid on it while you weren't using it, whereas some would take it off, and as they did the dyes, the lid would stay off the whole time. And so there was a lack of consistency from technician to technician based on how new their dye spacer was. If you look at the image on the right, The digital dye spacer, that is an absolute, exact, perfect 90 microns on the axial surfaces of that preparation and on the occlusal surface of the preparation too. So this digital dye spacer is a really good example of how the fact that we really fabricate crowns in this digital environment now, it's become much more consistent. So now we can not only make sure that it's 90 microns, but it's absolutely uniform, not only on this crown, but on every crown that's going to go out. We can also do that with the contacts. So if we want to have the contacts overlap by 10 microns, so they'll be just slightly tight, we can make them all overlap by 10 microns. Or if a dentist complains about tight contacts, we can set it at 0. So which means they're just kind of kissing and just touching like this, but they'll still snap when the floss goes through. And every crown will be designed like that. So we can do parameters like that, including occlusion. And it's one of the neat things about this digital environment that has really helped our consistency here. You know, as a large laboratory and you have a lot of technicians, there's going to be, or used to be, a lot of differences between the technicians and how they would do things like dye spacer, contacts, and occlusion, even though they were all instructed to do it the same way. And this whole digital environment and this CAD/CAM and monolithic revolution have made it so that we can actually provide a higher degree of consistency than we ever could before, because it's all being done in the computer by the software. So thank you very much for that question. And even though you don't see any dye spacer on your dies from now out, rest assured that there's 90 microns on it that has been designed into the restoration. So when the restoration was milled, if it was a Bruxer crown, for example, there's 90 microns of space on the inside of that for the cement space. But you won't see it on the die anymore, and you won't even be able to see it on the inside of the crown. But rest assured it's there, and it's as consistent and as accurate as we've ever been able to be. So thank you so much for that question.
Yes.
And what do we have for him?
Well,
sourdough bread.
No,
we can't do that.
No, but yes, of course, thank you so much to Stephen, and thank you to Dr. Nguyen for the bread. That was super sweet of him. But for Stephen, we've got, of course, this photograph of last week's episode 98, and I look like a kid in a candy store at this point in this picture. I'm not sure exactly what's happening.
You look super excited.
I
don't know what it is.
I don't know.
And I look like I have a wad of chewing tobacco or Red Man in the side of my side
It
of my
looks
cheek.
almost like my tongue's coming out a little bit. I don't know what that's about. I apologize.
You look like a tiny hamster about to eat a tiny burrito.
What is...
That's your video pick of the week, by the way.
Gosh.
Tiny hamsters eating tiny burritos. Watch it. Show it to your kids. Good, wholesome family entertainment.
It's weird. But anyway, so yeah, we'll sign this and send it out to him. And I don't know where Dr. Devins is from.
We'll look him up.
Okay, well, we will. But the reason why I ask, why I wonder where he's from, is because what kind of local special delicacy he might have that he could send us.
Oh, yeah.
To the dentist in Texas, I am willing to accept barbecue sauce. Anything to do with barbecue. Mm-hmm. I don't know. Anything. Wherever he's from. Let's see. What do you got, people?
Well, we'll look him up, and maybe we'll be able to send a suggestion along with that. And since he mentioned Bruxer, I'm going to send him a Bruxer adjustment and polishing kit. That was one of the things we did out at the Texas Dental Association was we had a hands-on clinic, and we allowed doctors to see what it was like to adjust Bruxer and Emax, see what it was like to polish it, recontour it, and then we cemented a Bruxer crown onto a fake tooth, an ivory tooth, and then they got to cut it off, which is great fun.
Awesome.
And so they got to do it with the wrong burr and then with the right burr and see what
difference.
A big difference that it makes. So it was a lot of fun. So I'm going to send him a Bruxer adjustment and polishing kit. Any news today?
Yes. In a bizarre twist to a kidnapping story, turns out a Texas woman was not missing as she had stated. She called 911 and claimed to have been kidnapped at gunpoint from a gas station, driven around for hours, sexually assaulted, then tied up and left alone in her Jeep. Police say now none of that even ever happened. Police checked the gas station surveillance footage and found nothing, so they questioned her. Upon questioning, it was then that she admitted to making the whole thing up. Authorities say she told them that her teeth fell out and she didn't want her husband to see her without them. She was arrested and charged with a misdemeanor for lying to a police officer.
Ah, the old fake kidnapping ploy.
I mean, it's so elaborate. Like, not just I was kidnapped,
Right.
but I was kidnapped at gunpoint,
Right.
driven around,
Right, sexually assaulted. She threw out everything but the race card. I'm
Right.
surprised she didn't throw that out as well, just to make it like a hate crime.
Oh my
A
gosh.
fake hate kidnapping crime. She said her teeth fell out. What
Right.
did she have a denture, or were they natural teeth? Did it say?
It did not say. I would, based on the story, I'm assuming it was
She must have lost a denture.
right. And she was saying that she had to make up the lie so that her husband wouldn't leave her.
So the husband, somehow she believed that the husband didn't know she had a denture. This reminds me of me thinking that nobody knew I had a hairpiece several years ago.
Bless her heart, bless your heart.
Right.
You know, and honestly, this obviously, maybe not obviously, but to me, I think this just screams like deeper issues, right? The issue here is not necessarily her just lying about a denture and making this whole thing up. Clearly, she's got some issues that she needs to get worked out with a professional.
Right. Actually, it reminds me of the first 8 weeks of your pregnancy where you didn't say anything to anybody, but we were all looking and you thought nobody noticed.
I knew everybody noticed. I
Okay.
couldn't say anything because I was waiting.
Right, I understand. Okay.
Give me a break.
All right. Anything else?
Yes. A new Gallup poll shows which states go to the dentist the most. According to the poll, residents of states in the Northeast are most likely to have visited a dentist in the past year, while states in the South are the least likely. For the third year in a row, Connecticut residents were the most likely to say they visited a dentist in the last 12 months. It is one of only 3 states, including Massachusetts and Rhode Island, where nearly 3 in 4 residents visited a dentist. On the opposite end of the spectrum, Mississippi comes in last for dental care. The top 5 states are Connecticut, Massachusetts, Rhode Island, Alaska, and Wisconsin. In the bottom 5, well, we've got Mississippi, Oklahoma, Louisiana, Arkansas, and Texas.
Wow, Texas and Oklahoma, step up your game. But California, is not in the top 5 either.
No.
I mean, that's kind of shocking. Alaska, really?
Thank you. And that was, for me, that was the biggest kind of surprise, based nothing on the people, the residents, but just on the sheer, vastness of Alaska. You would think that
Right.
there would be, dentists few and far between.
Right, you'd have to take a boat
or a
or a
dog sled.
seaplane or an Iditarod.
Right.
Enter the I killed a dog race to get up to a dentist and get pulled by a team of 12 huskies.
Sure.
But yeah, it's surprising because you just don't expect in Alaska. Maybe it's the pipeline money, or maybe there's
Right.
a state insurance thing that we don't know about. By the way, Dr. Devins from the Viewer Mail is in Cocoa Beach, Florida, is where his practice is.
Oh my goodness.
So
You
he's
know
in
what that
Florida.
means?
I don't. That he's in
3
Florida.
words.
Go ahead.
Key lime pie.
Really?
Yeah,
You're
I'm
craving
looking at
that
you.
now?
Yeah, that sounds amazing. That's the thing. I've been craving cold, refreshing treats. That's why ice cream is such a problem for me at this point.
Well, Steve, you can do key lime pie if you want. Well, you don't have to do anything, obviously. I'd prefer you send what I see here as a kind of a Florida specialty, and that is called swamp cabbage.
I want nothing to do with
Swamp cabbage is hearts of palm, comes from the cora, the small palm tree, common in Florida. A dish was first eaten by the Native Americans in the region,
My
who
people.
boiled the cabbage to make it softer, and then prepared it with tomatoes or cream. And so some swamp cabbage,
That sounds horrible.
I think you'd enjoy it more.
No.
You're probably craving it because you're pregnant and you don't even know it.
Okay, no, I don't think so. But anyways,
Do you like cabbage?
I do like I like
All right.
sauerkraut. I like cabbage.
And who doesn't love a swamp? That's what I'm saying. Swamp
this girl.
coolers. All right, we don't have to
Swamp
get that.
coolers?
Well, let's not beg for key lime pie. Let's just,
I'm not begging.
it's out there
I'm-
now in the universe.
Yeah, I'm just saying, Dr. Nguyen set the
Spoiler
precedent.
alert, that's the secret. We put it out in the universe and then see if it happens, just in
That's
case
the
you haven't
secret.
read that book.
I haven't, because it's nonsense. Go ahead.
Well, I'm a little disheartened to see that California is not in the top, but
I know.
what are you going to do? There's people without dental insurance, but leave it to the Northeast. That's where most of our dentists that we work with as
Sure.
a laboratory are, so I'm glad they continue to go and fuel the sales
There we are.
of this laboratory.
Yes.
All right, thank you for that. Well, that about wraps it up for the 99th episode of Chairside Live. On behalf of myself, Megan, Swamp Cabbage, the CSL crew, and everybody here at the lab, I want to thank you for your time and your commitment to quality dentistry.
We'll see you next time. And find out which state got an A. ICC, you screwed me up. It's true. Because it's states. Sorry. It's so sadly true. I'm losing brain cells by the minute. Well, Mississippi has something to learn from Alaska.
And that went on so long I can't remember what I was going to say.
know. It was. I really stink.
I really stink.
This week's viewer mail comes to us from Dr. Stephen Devins, and
As though this were some thing that we were doing for ratings.
drop the beat, yo.